Okay, we are now recording. As people last minute sign in. Any questions? Any material? Everyone watched the video? I'm hoping I did not check my YouTube views to see who watched it, but I'm assuming everyone has at least access to it, so you guys can watch that before tomorrow, because that's when the test is. I would probably watch it before then, if I were you. So no questions at all. Everyone feels like pretty expert on this material. Nope. I see a lot of no's, but no questions. So everyone's like, I still haven't studied yet. You have a question? Yes.
1 second, I'm gonna study it.
Okay. Feel free if you think you have a question, like, oh, I'm gonna go ask them that later. Chances are people will probably have the same question in this room.
It was the sweat glands. Isn't apocrine what is developed when you're going through puberty, not eccrine?
Did I say it backwards on the?
I think it's backwards on like the chart that you put up. And
Okay.
In the slide.
Let me double check that, and then I will go back and correct if necessary, or I'll put an announcement out.
Okay.
Yeah, if I said it backwards. Yes.
Can you explain? I was like looking at the chart about the concentration of stuff in the renal vein versus the renal arteries, and like how come with inulin and creatinine, since they're neither reabsorbed or secreted, the concentration is lower in the vein?
Because so the artery's bringing the blood in, and you're freely filtering that. So most of it gets filtered, not all of it, obviously, because otherwise your blood level would be zero of that essentially. But you would filter most of it through the glomerulus, and so your levels coming out in the vein would end up being lower. Right. So like, coming out from that, coming out from the efferent arteriole, you've had some of that product be filtered out, so the concentration's then lower in that case. Right. And then it doesn't really pick that stuff back up because a lot of it doesn't end up getting reabsorbed from the renal tubule. So all of it just kind of stays in the tubule and the filtrate and gets eliminated out. Any other questions? I got only 59. Any other people waiting to log in? You get some teamwork? That seems... I don't know. You know, teamwork is kind of an unfair advantage, but you know, I'm not here to pass judgment on you guys. It's your life. Non-judgmental here. No. Okay, so we're up to 62 at least. All right, so let's get started with the review. Only 25 questions. I was having a hard time kind of writing these over the weekend since I was like, well, that kind of gives away the test question, or that one gives away the test question. So it was kind of, I know I didn't want to give away all the test questions because I feel it's kind of, however though, I think these are probably still representative of what's going to be on the test. I did kind of ratchet it up a little bit from what our previous tests have been. So, you know, take that in stride. Like, it's good to have a little understanding of what the actual renal physiology is, GI physiology, all of that. There might be some kind of mental logic you're going to go through to get from step to step to step in order to get the right answer. So we'll see some examples of that on here. So we can't have 94 averages forever. That's just too high. I said, you know what? We really need to. It's past 4th of July. You guys have had a good break. Let's go ahead and just tighten the screw just a little, just a hair, right? Try to get you ready for farm. Just kidding. Okay. All right, let's get started with our test 3 review. Okay, blocking angiotensin II receptors would cause which of the following? What do we think? You guys remember angiotensin II, right? It's for that renin-angiotensin system. I'll tell you, having a really good understanding of this stuff now is going to help you so much in pharm when we get to stuff like hypertension and dealing with like what are the downstream effects of blocking some of these receptors, or you know, what are some of the compensatory mechanisms that occur secondary to having some of these effects here. So we'll talk about those a little bit. All right. So why is that the correct answer? Does anyone know? So angiotensin affects ADH and aldosterone. That is very true. It vasoconstricts. Yeah, so one of the things you're going to see is you're going to hold on to more salt. You're going to end up losing some potassium due to mainly which effects? So if you're holding on to more sodium but you're losing more potassium, where is that occurring? What's causing that? So it's going to be more of those kind of cortical collecting duct area, kind of the late distal convoluted tubule, due to the effects of aldosterone. Remember, aldosterone, because when we block the effects of aldosterone, those are potassium-sparing diuretics, right? So you see that balance there, and when you have increased aldosterone levels, you're going to be reabsorbing more sodium, but you're also secreting more potassium. So we see potassium hypokalemia being a potential risk for having increased aldosterone concentrations. So that's one effect of angiotensin II. We mentioned ADH is also going to be important here because that helps to reabsorb what? Water, right? Which is happening where? Yeah, it's going to be more like in the medullary collecting duct. That's where a lot of the concentration of the urine gets determined there, right? Based on how much either solute or water ends up getting reabsorbed based on several factors. But so again, why does it decrease GFR though? Why is blocking the angiotensin II receptor? Perfect. Yeah. So the efferent arteriole is the main factor here. So if you block the effects of angiotensin II on that efferent arteriole, you're going to cause vasoconstriction or dilation. Dilation, right? And so that decreases that hydrostatic pressure in the glomerulus. So you decrease that pressure, you end up having less force going through there, and so you're going to end up having less actual filtration occurring. So because of that, GFR goes down. And this is one of the things you run into where patients who are kind of chronically hypertensive, a lot of times they are maintaining their renal blood flow, one with prostaglandins, which we'll see affects the afferent arteriole, but also Ang2. And so if they end up having issues to where, or give them a drug that blocks the effects of Ang2 pretty dramatically, they can see a big drop in their kidney function, mainly due to that decrease in GFR acutely. Okay, so that's one of the problems you run into. That's why we always start low and go slow those kind of drugs for those patients so you have already kind of poor kidney function to begin with. Okay, would it make sense of that? Okay, all right. You should see a decrease in arterial pressure because, again, if we're blocking the vasoconstrictive effects, that would cause a decrease there. All right. A patient with CHF is edematous. Which of the following would help correct this issue? You should be able to get this one based on what we've already talked about. This patient's already got too much fluid on board. What hormone will help to correct this issue? Oh wow, teamwork doesn't always work. Interesting. So there's no group content on tests. All right. So why is that the correct answer? Right. So having that, and where does AMP come from? It's going to come from the atria, right? So it's that atrial natriuretic peptides. It already makes sense. Like, hey, you're going to pee out more salt, right? It's coming from the atria. So that increased stretch, which when you have edema and you're having kind of fluid backup, right? So you're having that increased preload due to having too much volume on board. AMP ends up stretching or gets released due to stretch of the atria. That gets released and will start to cause natriuresis, which means peeing out sodium. You end up getting rid of some of that fluid. So that's kind of one of the body's compensatory mechanisms when you have things like increased ADH secretion or increased aldosterone or increased renin, right? All right, fantastic. Okay, we did not add one extra K there. It would be inappropriate. Okay, increased activity of 5-alpha reductase will lead to which of the following effects? Oh boy, you gotta know what all these enzymes do. Let's see. It's impotent that you understand this. The question is, what does 5-alpha reductase do? Makes testosterone? Not quite. Close. But no cigar. Yeah, converts testosterone, so we'll see that in a second. Right, so 5-alpha reductase converts, what's the starter molecule? Testosterone converts it to
Dihydrotestosterone.
Dihydrotestosterone, right? So DHT, right? So having that conversion over leads it to be more potent, right? Because DHT ends up having a much more potent androgenic effect actually in the tissues. And so we have drugs that can block that effect, which can lead to some of these side effects. But by having increased activity, one of the big things you see is BPH, or that benign prostatic hyperplasia. Also some risk for prostate cancer, right? Because the more you're kind of stimulating those tissues to grow, the more likely you are to have mutations that can end up leading to cancer risk. And so prostatic enlargement certainly would be one of the things we would be concerned about. On the flip side of that, if you had decreased 5-alpha reductase activity, you have less DHT floating around. That's where you can run into issues of like decreased libido. You can have impotence developing from that. Also, when you have more testosterone sticking around, we saw that there's a certain enzyme that will convert that into what? Estrogen, right? So you have the risk for having more estrogenic activity, which means that could lead to things like gynecomastia, right? Because we can see some of that in male patients who are taking like a 5-alpha reductase inhibitor for their BPH. Yes?
Isn't there some conversion of testosterone to estrogen anyway?
Yeah, you're going to have a little bit of it, but by blocking this enzyme, you would end up shunting it more towards the other pathway, right? Which we'll talk about that enzyme. I think there's a question on that a little bit later. So, all right. Increases in serum calcium would cause which of the following? What do we think? Increased calcium. Did I mention in my rambling? I noticed that last video was very rambly. I was coming off of a 10-hour shift on Sunday. I did a 10-hour shift on Saturday as well, so I was a little tired. But I mentioned which animal we get calcitonin from, or we used to. Not horses. Horses, of course. Salmon, yeah, it's actually salmon we were able to get this from. So interestingly enough, calcitonin gets released in certain animals, and so salmon was one of the big ones that we were able to get this from. There's also another drug that reverses the effects of heparin. It's called protamine. We'll talk about that when we get to like anticoagulants and stuff in farm. That one also comes from salmon, but actually comes from salmon sperm, interestingly enough. So for whatever reason, I don't know how these scientists came up with finding all these different tissues and secretions, and we're able to say, hey, this is a good thing to reverse heparin. I don't know how that mental logic happened, but basically we were able to find that, man, salmon we get some decent drugs from. Also, if you ever see like insulin, like NPH insulin, that has protamine in it as well. So sometimes if you have patients who are like allergic to insulin, a lot of times it's due to the fact that they're allergic to protamine. Because really, like, you can't really be allergic to insulin, right? You'd probably be dead in a lot of cases, right? Because you produce your own insulin. But for those patients, they actually have a protamine allergy. But anyway, another digression. Me being rambly again. Okay. Oh, so anyway, so why increase calcitonin release in those cases of having hypercalcemia? Right. So it ends up decreasing it, right? So what kind of effects does calcitonin have? Right. So decrease intestinal absorption, decrease renal. Yeah, reabsorptions are going to excrete more through the kidneys, and then also you're going to end up having more bone deposition or more calcium deposition on the bone. So more osteoblast activity, less osteoclast activity. Okay, so calcitonin is going to be the flip of PTH. We saw PTH is going to have a big effect on increasing absorption from the GI tract, increasing reabsorption from the kidneys, helping to synthesize more vitamin D, and also, as I mentioned, parathyroids will also end up having an influence from vitamin D as well. So patients who have kind of chronically low vitamin D, they also will have stimulated PTH, right? Because that's one of the problems you end up seeing with like a lot of like inner city kids who had like really poor nutrition. That's why it's such a big push to get more fortified milk into schools, so that way they would have good vitamin D and calcium uptake. Because otherwise, if they're not getting it through their diet, where they're going to get it from? From the bones, right? So that's the only place the calcium is, and these kids are growing like they don't have good bone development because of that, and so you see issues like rickets that can come up, which is from vitamin D deficiencies and other issues of kind of poor bone development. So that's one of the big problems with that. So anyway, where does calcitonin come from? those parafollicular cells in the thyroid, right? So calcium comes from there versus obviously the parathyroid hormone comes from the parathyroids. Okay. Which of the following can enhance the gastric phase of gastric secretion? So we have multiple phases here. So we're enhancing the gastric phase. Or maybe you're smelling juicy Burger King fries over McDonald's fries or whatever it might be. All right. So why is it not smelling a juicy hamburger?
That's cephalic.
Yep, that's a cephalic phase, right? So that's your brain kind of integrating some of these external stimuli, saying, "Hey, we got food coming in. Let's go ahead and start the secretion process." Good. Why is it not protein breakdown products entering the duodenum? So that's the intestinal phase, right? So that's part of that intestinal phase. And what does that normally do to gastric secretion?
Decrease.
Yeah, usually so usually you're going to find that the intestinal phase is going to have more of an inhibitory effect on the gastric secretion, because once you have those products kind of hitting into the small intestine, they say, hey, we got enough products to work with here. Go ahead and slow that down a little bit, secretion of content, so that way we can start to digest what we already have here. Okay. How come it not have stomach pH less than 2? That should actually be inhibitory. So one of the things you'll find is that obviously there's going to be a limit to how acidic you want the stomach to be, and so there is still a negative feedback that can happen. So obviously increased stomach pH will also start to stimulate more gastric acid secretion, but here you'll find that once the pH gets down low enough, they'll actually have an inhibitory effect. You don't want to keep pumping out hydrogen ions, until you get too acidic, because that can even break down some of the stomach protective barrier and things like that. This is also one of the things that we'll see with patients who take antacids, right? So antacids, what's an example of an antacid? Yeah, Tums, like calcium carbonate is good because it helps to neutralize your stomach acids, and that helps with gastroesophageal reflux, right? So one of the things that can actually can occur is by increasing the pH within the stomach. That will actually lead to a rebound hypersecretory phase, where you can actually have even more stomach acids being produced at that point, and the patient can have reflux from that. Okay, so for some patients, it's not such a big deal. For others, it is, and so antacids may not be the best option for them. That's where we can use things like antihistamines. We can use things like proton pump inhibitors. We can use other drugs that will basically affect the actual secretion of the acid versus just neutralizing what's already there. Okay. And obviously, stomach wall distension, once you do have more kind of food stretching out the stomach, that does help to enhance that gastric phase, increase release into the small intestine. All right. Activation of V2 receptors would lead to which of the following? What do you think the V stands for? Not vitamin. Vasopressin. What's another name for vasopressin? Antidiuretic hormone. Reduction in serum osmolality. Okay, so why is it not excretion of dilute urine? Yeah, so that's what happens when you have someone who has like diabetes insipidus. They actually have either they can have a central problem where they're not releasing a lot of ADH, or they can have a kidney problem where they're actually the V2 receptors are being not activated appropriately. And so you kind of certain drug induced causes work more in the kidney. Certain like head traumas and brain tumors and things like that usually end up affecting the CNS more. But yeah, so having low activity at the V2 receptor would cause excretion of dilute urine because we're not sending out what type of channels or what type of transporters. Yeah, aquaporin channels end up not being exotized, I guess, onto the cell surface, so it's not going to have resorption of water. Why would it not be hyperkalemia? Yeah, if anything, it might cause like a mild dilution of potassium, so it shouldn't cause hyperkalemia like you would see with like inhibiting the effects of like aldosterone or something like that, right? Or blocking the effects of angiotensin, as we'll see. And again, with angiotensin, one of the things you'll find with, especially the medications we give, is that by blocking angiotensin 2, either by preventing the activation of it, by giving an angiotensin converting enzyme inhibitor, or by blocking the actual receptors, as you'll see there's kind of two classes of drugs there, they will both lead to hyperkalemia, or at least a small increase in potassium due to the kind of negative effects it has like on aldosterone and whatnot. Why would it not cause hypernatremia? Yeah, if anything, you should dilute out the sodium. So if you were to have a case where you had too much release of antidiuretic hormone, too much vasopressin, what do you call that? Yeah, SIADH. So what you end up having is way too much reabsorption of water, which can lead to a dilutional effect on the sodium in the body. So you can actually see hyponatremia associated with that, which can lead to all kinds of bad problems. So one thing we should, though, see when we have increased water reabsorption from the collecting duct, should see a reduction in serum osmolality. Okay. All right. I'm like in Mantis Toboggan making a rise in the ranks. I mean, he's already a doctor. He should know everything, right? Okay, so this test is looking for the presence of what? Hopefully no one gets surprised by any one of these anytime soon. Hey, it's a much different experience when you see that when you're actually trying for it, and then the other time when you're not quite trying for it. Not preventing it, but you're not really trying for it. There we go. Okay, so we're looking for human chorionic gonadotropin. Why are we not looking for like progesterone or estrogen? Yeah, those are always going to be secreted, right? So like they're always going to have some levels of those around, in varying amounts depending on kind of what phase of the cycle you're in. So those aren't really specific for being pregnant, right? Inhibin, why would that not be the case? Yeah, what does inhibin have an effect on? Yeah, it feeds back and inhibits FSH. So again, not really specific for being pregnant. Again, gonadotropin releasing hormone. Yeah, that helps to release things like LH and FSH, but that wouldn't be super useful for our purposes. But HCG is the thing you absolutely are looking for because that starts to get produced by what? Eventually, like the baby gets fed through the placenta. Yeah, so the placenta or kind of the developing tissues there start to release HCG, and the main purpose of that is. Yep, so it keeps that corpus luteum going, so that way you can have increased estrogen and progesterone levels to have development of the fetus. And so eventually, remember, we saw that it kind of spikes up early on in the pregnancy, and it's going to go back down at a certain point once the placenta is able to make its own progesterone and estrogen. Okay. All right. And so you can check this either in the urine, obviously, as we see, or you can check it like in the blood. So either one you can see being done like in the hospital setting. Yes, sir.
This might be kind of a stupid question, but when you're saying that the corpus luteum is going to produce the progesterone and estrogen, I thought it was a progesterone and estradiol. So how do you
Yes, I use estrogen as the blanket term. That's probably my fault as coming from the pharmacy standpoint, because we just say estrogens, because all of them are acting essentially the same, right? So whether you're dealing with estradiol, whether you're dealing with ethinyl estradiol, or conjugated estrogens, they essentially will have pretty much the same activity, a little different potencies between them. But yes, you're absolutely right. So estradiol is going to be one of the main ones that we'll be looking at. But obviously we saw the estriol, estrone also get produced, but estradiol is the main thing there. Yes, I'm just speaking in more kind of generic term. It's difficult because progesterone, that's the main one we make anyway. So I say that, but when I talk about it for oral contraceptives and things like that, we'll talk about lots of different types of progestins that will be utilized in order for birth control purposes or whatnot. But yeah, so you're absolutely right. Estradiol is a correct terminology there. And I should be more specific. Okay, moving on. Which area of the kidney would have the most concentrated filtrate? And the ones listed here. We think. What do we think? The thin ascending loop of Henle. Okay, so why is this the case? Dip down as far because okay, that's not a good answer. Okay, so your patients ask you, how come they get so concentrated there? Because patients don't like that. Yep, yeah, it's just the way it is. That's the way God made us. Right. So when you're having basically when you're the filtrate coming out of the glomerulus into the proximal convoluted tubule should have what kind of osmolarity? About 300, right? So it should be isotonic to what's in the actual plasma. Okay, so that makes sense. Because again, sodium and water get reabsorbed essentially at the same rate, and so not much else changes. So essentially you have basically the same isotonic type fluid. As you go through the descending loop, what's happening there? It's getting more concentrated, right? Because you're reabsorbing water, right? So that's part of that countercurrent multiplier we talked about. And then as it kind of goes back up through the thin ascending loop, that's when you're going to have the most concentrated, right? So maximally you can see 1,200 milliosms essentially of solute. And so as it starts to come back up and then gets into the thick ascending loop, what happens there? So there's some diffusion, but you're also going to have a lot of reabsorption of solutes at that point, right? Because you're going to have that sodium, potassium, chloride pump. And again, that's where the loop diuretics are working. That's really what kind of working overdrive to pull all that solute back in. So by the time you get to the distal convoluted tubule, what kind of osmolarity are you at? Is that hypertonic or hypotonic? It's hypotonic, yeah. So you're really kind of going overdrive and reabsorbing solute. So you're around 100 or so. And so that's really important because working with that dilute urine, that allows us to be able to either concentrate it or to make it more dilute, right? And so we see that, there's that obligatory urine loss every day that in order to get rid of waste products. So there's only so concentrated you can make the urine. And what helps to make, so when you start out with that hypotonic fluid there, that filtrate, it's only about 100 milliosms per liter. How do we get that more concentrated? How do we get that to that 1,200 milliosms? Yeah, ADH is going to be one of the big ones. So when you're in that case of hey, I need to hold on to as much water as I can, those aquaporin channels reabsorb a ton of that water, and that's where you get a lot of that concentration there. Again, mostly that's going to be urea that you're going to be excreting at that point, right? Does that make sense? So again, it's going to be much more kind of when you're in the collecting duct, the actual concentration is going to be much more variable based on your ADH levels, based on several other features. But it's good to know kind of where the actual concentrating and diluting effects are actually occurring.
At the end of the descending loop and the beginning of the thin ascending, where is the water going?
The water is being reabsorbed either back into those paratubular capillaries, or it's going to be into the interstitium. So again, from the interstitium into the paratubular capillaries. So that's why you end up seeing that when you're having, you're causing the thick ascending loop is reabsorbing a lot of that solute, so all of it's getting concentrated right there in the interstitium, but then you have the water coming in from the descending loop starting to dilute that a little bit. So that's where you kind of saw that process occur, to where you get it's going to be much more kind of dilute at the top, and then as you get deeper and deeper in the medulla, it's where you're going to see it much more concentrated. All right, fantastic. And this is important because you may be thinking, like, well, who actually cares about this stuff? But it does become important. You're dealing with some of these nephro patients. When you have acute kidney injury that occurs either due to drugs or due to hypoxia, due to hypotension, due to several different features, you can get what we call dumb kidneys, essentially. I call them dumb kidneys. No one else probably does that. But you're still making urine. Like, the patient can still produce urine. So you think, like, well, the renal function must be great. But the concentrations are totally off. They're either not able to concentrate it appropriately. They're losing a lot of electrolytes, so they can have big issues with it, whether, even though they're having what looks like decent renal function, you go back and look at the actual, BMP and look at the electrolytes, and they're all over the place. And so that can be a result of having this impaired concentrating ability within the kidneys. So it's not a super uncommon thing that you'll see with some of these more sick patients. All right. Okay, moving on. Pernicious anemia may result from dysfunction of which cells? What do we think? Because these cells are not producing what? Intrinsic factor, which helps us to absorb what? B12. A lot of note flipping. All right. So some of these are a little straightforward. So what do you think mucus cells produce? Probably mucus. What do G cells produce? Gastrin, right? Which is going to have, what effects does gastrin have? Stimulates HCl secretion. What else does it do? Some positive effects on light pepsinogen release, right? Remember that? So then, and then what do our chief cells do? That's going to be releasing pepsinogen, which gets converted by HCl into pepsin, right? So then we can start to have some tenderizing of the meats and things like that going into the GI tract, some of the proteins. The parietal cells, what else do they release in addition to intrinsic factor? HCl, right? So that's going to be your primary place where the proton pumps are going to be working. It's going to be spitting out a ton of hydrogen ions. Good. All right. Moving on. Which of the following lipoproteins contains the largest amount of triglycerides? I think when I do this again next year, I'll probably going to include more detail on cholesterol metabolism and whatnot, because I think it's probably didn't spend quite enough time on that. We'll cover it more in pharm when we talk about anti-lipemics. Okay, so the answer, VLDL. Why do we think it's VLDL?
VLDL transports triglycerides.
That is true. Thank you. It's a very succinct answer. Absolutely, yeah. So that's kind of the key feature there. So basically, as you're absorbing cholesterol and triglycerides and things like that from the GI tract, the liver is going to start to convert it over into these lipoproteins, which obviously contain what two components? lipids and proteins, right? So again, we're going to have our apoproteins, which are going to be responsible for a lot of cell signaling and things like that. So look at the ApoB protein and whatnot. The other lipid components are going to be triglycerides and these cholesterol esters, right? And so you're going to find when you start out with the chylomicrons, there's a huge amount of triglycerides. Those eventually get converted over to the VLDL, the very low density lipoprotein. So that's where you're going to find that the highest amount of triglycerides are going to be living at. And then as that gets transported through the body, it's going to be donating triglycerides, donating cholesterol in order for, to do things like hormone synthesis and cell wall production, all kinds of different things. And as it starts to lose more and more triglycerides, that concentration of cholesterol esters goes up, and you're going to go to the intermediate density lipoproteins. Then you're going to get to the low density lipoproteins, and obviously those are going to be more at risk for causing things like atherogenesis, or causing those plaques to form in our vessels, which you don't like. And then finally, you're going to have HDL, which is responsible for kind of transporting a lot of stuff back to the liver in order to get removed, right? One of the things you also run into is that the liver does express LDL receptors on it, which helps to uptake a lot of the LDL molecules, right? So that way we can metabolize them, do whatever we need to do to get rid of them. And so one of the problems you find with patients who have chronically high LDL is, what do you think those receptors do? They end up downregulating it, right? So the liver's like, hey, we got enough LDL here, we don't need to really worry about this. And so that's why some of the things that we do to affect LDL are actually to inhibit the production of things like LDL within the liver and the production of VLDLs and IDLs. And so by doing that, by inhibiting the actual production of those cholesterol molecules within the liver, that actually helps to upregulate receptor output onto the cell surfaces. That means they'll uptake more of that LDL, metabolize it, get rid of it, and then your levels start to drop, right? And then you may see some rise in your HDLs as well, secondary to that. But anyway, so that's essentially what we're seeing there. So again, the highest amount of triglycerides, again, these are going to be the more atherogenic kind of molecules, LDL especially, since that's kind of the more predominant one we'll see there. Okay. And again, you can kind of get an indirect measure of your VLDL concentration, because when you do your lipid panel, you can look for things like HDL concentration, LDL, and you can actually count for the VLDLs mainly by looking at the triglyceride count. So it's kind of used as kind of a surrogate for the VLDL concentration. And so when you're looking at things like total cholesterol, there's a little conversion you do with the triglycerides to get that. Cool. Anyway, moving on. All right, which of the following associations is incorrect? Incorrect. I think I put one not question on the test. I usually try not to do that, but I ended up doing it on accident. So read your questions very carefully tomorrow. All right. Why is this one incorrect? We just talked about it, right? So gastrin is going to do what? Yeah, it's going to be more affecting the stomach more so than the pancreas. So again, Motilin absolutely is going to increase motility, kind of right there in the name, and we try to utilize that. Certain drugs we can utilize for kids that have like problems like slow GI transit time. GIP, what's the GIP stand for? Gastric inhibitory peptide, right? And so does that increase insulin secretion? Yeah, it does, because that was correct, right? So we see, right, and it makes sense when you think about it, like it's gastric inhibiting peptide, right? So you're having a lot of contents coming from the stomach into the small intestine. You're starting to break down a lot of those starches into more of those kind of single monosaccharides, your glucose and whatnot. How does that occur? What enzyme does that? We'll break down your carbohydrates. Yeah, so pancreatic amylase starts to break a lot of those down. We can then absorb it. It's going to be a more readily absorbed form. You guys remember what glucose gets absorbed with? Yeah, I remember that sodium cotransporter, so that helps with the absorption of sodium and glucose there. And so as that starts to come in, like, okay, you got a lot of blood glucose going up, so you imagine seeing that after you eat. Having this gastric inhibitory peptide will feed back and cause some inhibition to the gastric gastric activity, but also is going to help to stimulate insulin release, right? Because again, you know you're going to have increased blood sugars. You want to have that insulin coming in, help to lower those and shuttle glucose to whatever tissues it needs it, right? And then cholecystokinin, what else does that do besides just contracting the gallbladder? Yeah, so it really helps to release a lot of those pancreatic enzymes from the pancreas. Again, you don't see a ton of that water and bicarb secretion that you see more often with things like which hormone? Yep, so secretin is going to be the big one. So I think CCK, increasing more enzyme release, but not necessarily a lot of the water and bicarb. Think about secretin as releasing a lot of that water and bicarbs. That's kind of one of the big things that helps to kind of flush the pancreas out and spit all that out into the small intestine. Okay. All right. Which of the following is used to digest proteins in the GI tract? This was when I was at the point I was stretching for questions. How could I still feed a patient but prevent them from releasing a lot of these enzymes? Feeding below the stomach? Depends on where you feed them at. Yeah, IV is going to be the biggest thing that we do that. That's why we do a lot of like gut rest when we have patients with pancreatitis. And so we will give them intravenous nutrition. So we had, like I mentioned, one patient with necrotizing pancreatitis and was able to help prevent them from that. Okay, so why chymotrypsin? Remember, there's a couple of different protein-degrading enzymes get released by the pancreas. Trypsin is going to be the big one. It's probably the most common one. You're going to have chymotrypsin in smaller amounts, and then there's a carboxypeptidyl blah, 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 which I need to look at again. So that would not be the amylase does what? Yeah, breaks down sugars, gastrin. Yeah, it doesn't actually catalyze any of those reactions. It just helps to secrete more release of things like HCl and whatnot, right? So that would not be the case. And then trypsin inhibitor, what does that do? Inhibits trypsin, which does what? What does it prevent us from doing? Yeah, preventing auto-digestion of the pancreas. Perfect. All right. Which of the following would be true in a female patient taking oral hormonal contraceptives? It's just screwed you and put like a male patient and see whatever I thought. All right. Why is this the case? Negative feedback. Yeah, absolutely negative feedback. So think about, we're giving someone exogenous estrogen and progesterone, right? We are having that feedback to block release of what? GnRH, right? So those levels should be low because they have a negative feedback. What else is low? LH and FSH, right? So all three of those should be low because they're being suppressed by the exogenous products that we're giving them. Progesterone production is increased. Why is that not the case? Okay, so we're reducing things that stimulate also what is not actually getting produced during this phase, because we're preventing ovulation is the main goal here, right, for contraceptive purposes. Yeah, so you never really get the corpus luteum being produced there, right? So again, you don't ovulate, you don't produce that corpus luteum, and so in that case, progesterone secretion really would never be increased. And again, we're giving progesterone anyway, so again, that would also help to provide that negative feedback inhibition there. Okay. Make sense? All right. Now again, their progesterone levels may be higher, mainly because we're giving them exogenous progesterone, but they're not actually producing it themselves. In a lot of cases, we're giving them like synthetic progesterones, as opposed to like sometimes, like we mentioned, like that Premarin, which is conjugated estradiol, like that we're actually getting that from certain animal sources in some cases. But progesterone is usually synthetic in a lot of cases, but they're not producing their own. Okay. Which of the following hormones could be considered to be catabolic? It's not dogabolic. Catabolic. I misspelled testosterone. I meant testosterone. All right, so what do we mean by catabolic? Breaking down things, right? So we're breaking down proteins, we're breaking down fats, versus anabolic, building it back up, right? So things like estrogen, which I misspelled that as well. Obviously, I was getting a little tired when I was making this. Estrogen, that would be anabolic, right? Because you're helping to develop, a lot of, breast tissue and uterine tissue, things like that. Insulin also can be considered an anabolic hormone, mainly because you're increasing, uptake of different molecules and nutrients by the tissues, right? So that would be considered to be anabolic. And testosterone, obviously, you consider that kind of the prototypical anabolic steroid, right? But cortisol, on the other hand, when do you release cortisol? When you're super stressed out, like for the next 2 years, you guys' cortisol concentrations are going to be skyrocketing, right? Probably you'll see like a pretty sharp increase through the fall and winter semesters, and then as you get into second year, it'll probably drop off quite a bit, and then when you go to take your pants at the end, they'll probably spike up again, right? But you should be seeing these kind of catabolic effects mainly because you're in a stress state, you need more energy, so you're going to start to break down fats and proteins and whatnot. Okay. All right. Dr. Toboggan in the lead. Okay, stimulation of the facial nerve will cause increased secretion of which salivary gland? I guarantee you this is the most I've ever thought about cranial nerves in my entire life. Like, clinically, stuff does not seem to come up very often, at least from the pharmacy side. But you gotta cut your teeth on this stuff, you gotta learn it. What do we think? There were 2 right answers, haha. So remember, all right. So submandibular, sublingual, both going to be from the facial nerve. What do they end up secreting mostly? They're kind of a balance, right? So remember that like the buccal glands, like they're mostly going to be mucus. Here you're going to see some balance between mucus secretion, also that tailin secretion. So that's going to be helping to start to break down those sugars and whatnot. Okay. Which nerve goes to the parotid? 9, right? Okay. Fantastic. Okay. Continuing on. Patients with a vitamin A deficiency are likely to complain of, help, I'm low on vitamin A. When you get scurvy. Low on vitamin C, yeah. Do you know what a pirate's favorite letter is? R. No, it's the C. What have you never heard that before?
Oh boy.
Impaired nighttime vision or low light vision. Yeah, absolutely. Because remember, vitamin A produces what? Rhodopsin, right? We need rhodopsin for light detection. So especially, they end up complaining more of low light vision issues. Highlight situations they can see just fine, but usually you have some issues, kind of differentiating between objects and things like that, kind of in the dark. Fantastic. When would you see excessive bleeding? Yeah, vitamin K, absolutely. And then mucositis is kind of a common one, especially a lot of the other like trace elements and things like that. So it's not super as specific as you might see with some of the other things. Okay, so moving on. Right. The drug Leuprolide or Lupron is a GnRH agonist. Chronic administration of this would cause. This one's a little tricky. Chronic administration. Not administration of the chronic, just chronic administration of this drug. Don't feel bad if you don't get this one right. This one's kind of tough. So there's also 2 right answers here. All right, so you're thinking GnRH stimulation. What should that do? Should increase LH and FSH, right? Which should increase testosterone and estrogen production. Chronically, it does not do that. So if you remember, and so actually what you can find if you ever look at indications for this drug, it can be used for short courses of the therapy. It can actually be used for patients who are having infertility. You can actually use this to kind of kickstart the system a little bit, stimulate some LH, FSH, and then either estrogen or testosterone. But chronically administering this drug is called, another name for this would be chemical castration, essentially. And so what this does, if you remember, what's kind of characteristic of GnRH release in the body? It's pulsatile, right? So you get kind of peaks and valleys that occur there, and that helps to stimulate LH and FSH. When you give chronic administration, you're agonizing those GnRH receptors. Basically, what you end up finding is you have a major reduction in LH and FSH. You have a major reduction in testosterone and estrogen production. So basically, make them completely infertile, have all the other side effects associated with dropping those levels of either estrogens or testosterone, right? So again, sometimes you have to think about like, well, okay, well, how is this medication or how is this substance being administered like over a long period of time? How do those effects change versus just short course therapy? So just something to kind of get you guys thinking a little bit. Remember that pulsatile release of GnRH is important and kind of integral to its function. All right. Bless you. What's the name of this creature? This is not for points.
I remember this one.
Give away the answers. Gotta find out who my Star Wars nerds are. They Sarlacc pit. This is where Boba Fett got thrown in at the end or at the beginning of Jedi. Yeah, right. Definitely not a Wookiee. Who's a Wookiee? Chewbacca. Who's a Gungan? Jar Jar Binks. Yeah, everyone's favorite Star Wars character. Yeah, that would be a Mon Calamari, actually. Admiral Akbar. Hate to correct you. Anyway, all right. Moving forward. I should not reveal this much of my nerd this early on in our time together, but all right. Okay, which of the following are responsible for amino acid reabsorption in the kidney? This is really just to remind you, oh wait, that's a thing. Secondary active transport. All right, why is it not osmosis? That's just water. Yep. Not aqueous diffusion as well, because why? Yeah, it's water, and also it requires a transporter in order to get it across, right? So it's not counter transport, because why? Right, because sodium and amino acids are going in the same direction, right? So it's actually a co-transporter. You guys remember that, right? But why is it secondary active transport? That sodium ATPase pump, right? Remember, so the sodium potassium ATPase pump is working to bring sodium from the renal tubular cell, right? So out from the lumen to the tubular cell, and then eventually is going to get reabsorbed back into the interstitium. Okay, so you cause, by that pump having increased activity, you cause that diminished level of sodium within the cell, which causes basically kind of a sodium sink, essentially, which is going to draw sodium in from that renal tubule. Okay, that's going to draw, because it goes through that co-transporter with amino acids, and also remember glucose could be going through a co-transporter as well. It's going to draw it in from the renal tubules. That's why you have so much reabsorption of that occurring along with sodium, right? And remember, like, how much absorption of sodium occurs in that proximal convoluted tubule? Yeah, roughly like 2/3 of it. So a lot of sodium's coming in. You get all that amino acids and all those glucose in. Yes.
So even though it's like a co-transporting, the co-transporting part, is that sort of like passive?
Exactly. Yeah. So that's a key thing there, is that co-transporter does not require any energy, right? The energy, so it's it's still considered facilitated diffusion, but it's still passive, right? Because it doesn't require any direct energy. But the reason that it works is because you're making that concentration differential between the renal tubule and the actual the cell, because of that ATPase pump is working so much. Yep. Awesome. Okay. It's toboggan staying out in the lead. Which of the following pairings is incorrect? Like a steak and red wine, or that'd be correct pairing. All right. So what should the correct answer for that be? Ileum to the colon. Yeah, so that's pretty straightforward. Most of those sphincters are pretty well named there. You can kind of guess what they should be connecting up there. Yeah, everything else would be correct in that case. So just to jog your memory. Okay. Inhibiting prostaglandin synthesis would have which effects on GI function? What are prostaglandins doing for us? I'm sorry, inhibiting prostaglandins, which effects would it have? Yes, it would have increased HCl secretion. So why is that the correct answer? Because prostaglandins have an inhibitory effect on that proton pump, right? If you go back to your slide where you're looking at the different influences, things like acetylcholine, things like histamine, things like gastrin, you saw that prostaglandins actually have a protective effect on the stomach. Increased activity would block HCl secretion, or at least to some degree, at least diminish it a little bit. But also, what's the other important thing that prostaglandins do? Yeah, mucus barrier is really important there, right? So that's why, and then you'll learn with certain enzymes that some will be constitutive and some will be inducible. And what do you think constitutive means? Yeah, it's always being released, right? And so you'll find that certain prostaglandins are always going to be released because they are needed for these kind of constant functions. And so cyclooxygenase 1, or COX-1, is the enzyme that's really responsible for producing like prostaglandin E2. That's kind of the one of the big ones in the stomach. And so if you have something like a non-specific NSAID, something like ibuprofen, it can block both COX-1 and COX-2, COX-2 being the inducible one that occurs when you have like inflammation or injury. So you can inhibit that, and that's why you see gastric ulcers that can form secondary to utilization of NSAIDs. So that's why I tried using like selective NSAIDs and try to spare some of that effect. But those are it's important to know kind of what the downstream effects from inhibiting some of these products is. Okay. Again, prostaglandins really shouldn't have a whole lot of effect either on peristalsis or on gastrin secretion directly. So that'd be the main thing there. All right, Slaginator coming up in front. Which of the following would cause constriction of the afferent renal arteriole? This is going back to our autoregulation. What do we think? Cocaine-induced release of norepi. All right. So, what does autoregulation do for us? Yeah. Despite whatever changes in blood pressure you have within limits, you're going to keep essentially the same GFR, right? So that's going to be based on either constriction or dilation of either the efferent or the afferent arteriole, right? GFR should remain pretty constant through a range of different arterial blood pressures. So what would diuretic abuse cause? So directly diuretic abuse would cause what? Well, before you get to the autoregulation aspect of it, what's it doing to the body essentially? So it should have decreased blood volume, right? So decreased blood volume, what should that do to your blood pressure, if anything? Should drop it to some degree, right? So blood pressure is dropping. What is the autoregulation response to that going to be? It's going to dilate because you want to increase the amount of blood flow getting to the kidneys, okay? So it's going to dilate, and that's going to help keep GFR essentially the same, right? Because your blood pressure is going down, pressure coming in, so it's going to dilate that afferent arteriole. Okay, good. Massive hemorrhage, same thing. Low blood volume, we're going to have a dilation of that afferent arteriole in order to make sure we can keep GFR high, or at the right level. Hypotension due to infection. Same thing again. So again, either whether it's due to a lack of blood volume or it's due to the fact that you're having either very leaky capillaries or you just have hypotension in general, those would all cause dilation of that afferent arteriole to get more blood flow in. On the other hand, cocaine-induced release of norepi, again, I would not recommend it, even though you may need to study a lot. It's not the answer. That should cause what? Right, so you see vasoconstriction because now the blood pressure coming into the kidneys are going to be too high, right? So, and you can see this with some of these guys that, you know, they stroke out from having way too much cocaine on board. They get very, very hypertensive. The response of the kidneys to maintain that GFR is to constrict down to prevent some of that pressure from coming in, right? So blocking that increase in pressure by constricting that vessel decreases the hydrostatic pressure within the glomerulus. You have GFR remaining about the same. Okay. Again, unless you get like, you know, a systolic of like 200 or something, then, you know, the kidneys can only do so much. And at that point, you kind of go outside those ranges of autoregulation. Okay. Which of the following would not be a potential side effect of inhibiting the aromatase enzyme? I do a lot more not questions in the reviews than I do for the actual test, but not a potential side effect of inhibiting aromatase. or inhibiting something. What would not be caused by that? Yes, kind of like a double, triple negative. First question though, what is aromatase? All right, so aromatase does what for us? Makes the girl stuff. That is my new favorite answer for that question. More scientifically, what does it do? Yep, so it converts things like testosterone over into estrogen, right? So this is responsible for a lot of the estrogen production. By inhibiting that enzyme, we should do what to estrogen levels? Should decrease estrogen levels, right? So that can be very important. This is, we used to use these drugs, not quite as much nowadays. We used to use them for things like breast cancer, right? So especially estrogen receptor positive breast cancer. So these women would have tissue that was very responsive, or breast tissue that was very responsive to estrogen, and that would cause stimulation of growth, and that way you'd see, increased activity of those cancerous cells, right? So we would give a drug like an aromatase inhibitor that would actually block the production of estrogen and would decrease the amount of actual activity going on, that kind of pro-growth activity you would see in the breast tissue. So we sometimes still use it for refractory cases, but not quite as often due to a number of the side effects you see from systemic drops in estrogen levels. So what those things that you might see, why would you see fractures? Right, so estrogen has positive effects on the bone to lay down new calcium, so you would lose that effect, so you see osteoporosis being a risk. How about hot flashes? Also related back to estrogen deficiency, so you see this kind of cutaneous vasodilation, you get this kind of very flush, hot, sweating kind of reactions. And then vaginal dryness. Yeah, it's all based on estrogen, right? So if you have decreased estrogen activity, you're going to have atrophy of that tissue. You're going to get less blood supply. It's going to get dryness and more risk for infection, things like that. So that's why sometimes you may see a patient on like an aromatase inhibitor, and they'll also be like on a locally applied, like a topical estrogen product they can place directly in the vagina to help kind of resupply that tissue with the kind of pro-growth effects. But breast tenderness should not be one. Why? It's less estrogen, so you're not going to really have as much activity at those tissues, so you should not be promoting growth there or promoting increased development of that tissue. Okay, make sense? All right. Moving on. What more we got? 3 more questions. All right, majority of fluids found in semen comes from the... Seminal vesicles, yeah, produce a lot of the fluid. Where's the sperm actually produced? Yeah, they actually get produced in the seminiferous tubules, and then they get stored where? Yeah, the epididymis, yep. And then what's the vas deferens help us with? Basically, how they're traveling over into through the prostate, which prostate helps to give us what? Yeah, some kind of miscellaneous products. It helps kind of give it that. It helps with certain clotting factors and things like that. So kind of a mixture of stuff. But remember, the seminal vesicles also release a lot like fructose, which we utilize for energy there. And then after once the seminal vesicles have kind of donated there, where's most semen stored? On a boat. That's a joke. Get it? Just add an A there. Okay, moving on. I thought that would play a little better. I was kind of chuckling to myself on that one. Guess not. Okay, patients with liver dysfunction will have problems making to the following. Oh boy. All right. Remember, the first activation step occurs where? In the liver, right? So the first activation step, so that's where you convert things like cholecalciferol, which is like if you're looking at exogenous, either from our diet or from like drug products, you usually either get the ergo or the cholecalciferol. That eventually will get converted, and eventually in the liver, you get that 25-hydroxy cholecalciferol. It's kind of the first step there, and then it goes to the kidneys, and that's when it gets converted over in that 125-dihydroxy, right? So it's just the secondary step there. Yes, ma'am.
What was the first one you said? The first step?
The first activation step happens in the liver. That's where you get that conversion over to 25-hydroxy cholecalciferol.
What is it being converted from?
Either like the cholecalciferol, typically, like a lot of it gets converted over to that D3, and then it converts over to 25-hydroxy vitamin D. Yep. We oftentimes will give those interchangeably. It just depends on what drug products we have on hand. I probably see the majority, at least my patients, get put on vitamin D3. It's a common pediatric administration. Sometimes for patients who require very big doses, I see them use like the D2 sometimes. So if they need usually a typical dose for a patient would be like 400 units of vitamin D3. Some of these patients that have like issues with either usually vitamin D deficiency, we may give them like 40,000 units of vitamin D2 or something, so a very, very big dose to try to help get them kind of back at a steady state level. So, okay. Next up. Quick, a bear has run into the classroom. Which of the following are occurring? I'd be creative with some of my abbreviations. This Professor Austin likes these alligators, but I figure bears seem a little bit quicker and be a little more scary. Although alligator attacks are much more likely, especially in the pond out here. This one's a little tricky. So, okay, interesting. Okay, so let's work through this to make sure we know why the correct answer is what it is. Okay, so increased norepi effect. So again, when a bear pops through, hopefully most of you should have a fight or flight response, correct? Most people just love bears and they're like, oh, I'm gonna snuggle up with them. In which case, so you should have a released norepi, right? So increased norepi on the detrusor muscle, should that cause constriction? No, it should actually relax that, right? So if you're having a fight or flight response, you don't necessarily want to go to the bathroom at that point, right? You're trying to hold on to things. You may end up going to the bathroom just due to shock, I guess. But you're going to find that you're going to have a relaxation there. It's going to help to hold on to more urine. Yes?
I thought relaxation allowed it to open.
Relaxation of the detrusor muscle allows for better storage of urine, right? So when you get to the actual internal and external sphincters is where the constriction prevents outflow. Okay, so when you have relaxation of the detrusor muscle, you're going to have less pressure there, less stretch going on. You can store more urine, right? So that would not be the case on this one. Now, what causes the detrusor muscle to constrict? Acetylcholine, right? And that's coming from which kind of nerves? Parasympathetic nerves, right? So parasympathetic nerves release acetylcholine onto what type of receptors? Muscarinic receptors, and that would cause constriction. So this would not be the case for that. And again, you're not in a very parasympathetic kind of state at that point, right? You're not in the rest or digest state. Increased norepi effect on the internal urethral sphincter causes relaxation. Why is this not correct? Should be constriction, right? So you want to squeeze down on that because you don't want to necessarily go to the bathroom. You want to have inhibitory effects there to hold on to that urine, okay? So that not being correct. But why is this one right? Increased acetylcholine on the external urethral sphincter causes constriction. Okay, so again, what type of nerves is releasing these acetylcholine? It's not parasympathetic technically, right? So this is coming from that pudendal nerve, right? So these are releasing acetylcholine onto what type of receptors at this point? Nicotinic, right? So this is different. This is acetylcholine being released onto nicotinic receptors. This is under our conscious control to some degree, and so we're going to cause constriction of this in those cases, right? So we want the constriction so that way we're not accidentally going to the bathroom when we're trying to run away, okay? So it's a decent defensive tactic, but I would not recommend it, right? Okay, anyway, so that makes sense for everyone? So remember, kind of like, you know, the parasympathetic and sympathetic effects are not really under our control, but that external sphincter is under our control, and we can do that through nicotinic effects on acetylcholine, right? If we want to go to the bathroom, we want to have micturition, then we would send an inhibitory signal down, and that would decrease the release of acetylcholine on those nicotinic receptors and will cause relaxation, right? Okay. All right, so Mantis Toboggan, using the dentist system, I imagine, has won. Who's Mantis Toboggan? Fantastic, good job. Slaginator, nice, nice. And then Quasedrifgi, nice, all right. I'm sure that has very significant meaning to you. I won't ask you to share. Okay, so that is the final results. Any, oh yeah, the free answer, D. Yes. Okay, any questions based on this? All right, I'll try to answer questions via email or in my office throughout the day and evening. But with my daughter's recent sleep habits, she should be up until like 11 o'clock tonight, so I'll be up late anyway. I'm not bitter. Okay. All right, thanks, guys.